What are the key components to interpretation of a bone mineral density test? Question. What essential factors must physicians consider when interpreting a bone mineral density (BMD) test, and how do these contribute to the accurate diagnosis and management of conditions like osteoporosis? Answer. Interpreting a bone mineral density (BMD) test is a complex process that requires consideration of various components to arrive at a clinically meaningful diagnosis. The assessment of BMD plays a crucial role in understanding bone health, with its influence extending to the diagnosis, risk stratification, and management of osteoporosis. Here's how the key components work together. T-score and Z-score interpretation. The T-score compares the patient's BMD to that of a healthy young adult population, while the Z-score compares it to age-matched controls. A T-score of is less than or equal to 2.5 is diagnostic of osteoporosis, while a Z-score of is less than or equal to 2.0 may suggest secondary causes. Incorporation of risk factors and FRAX calculation. Utilizing the patient's clinical risk factors along with BMD, the Fracture Risk Assessment Tool, FRAX, calculates the 10-year probability of fractures, guiding treatment decisions. Alignment with clinical context and guidelines. Interpreting BMD must align with established clinical guidelines and take into account the patient's overall clinical picture, such as age, sex, medical history, and individual risk factors. Monitoring and treatment implications. Regular BMD monitoring helps evaluate treatment response, while understanding limitations and artifacts ensures accuracy. Facts associated with the interpretation of a bone mineral density test, including statistics. 1. T-score is less than or equal to 2.5. Diagnoses: osteoporosis. About 10.2 million Americans over age 50 have osteoporosis. 2. Z-score is less than or equal to 2.0 may require evaluation for secondary causes. 3. FRAX calculates a 10-year fracture probability. Fractures cost the U.S. approximately $19 billion annually. 4. BMD measurement commonly involves the spine and hip. 5. Regular monitoring detects changes over time. Treatment reduces fracture risk by 30 to 50%. 6. Precision error is typically around 1–2%, significant when monitoring. 7. Inclusion of individual risk factors refines interpretation. 8. Follows established guidelines. National Osteoporosis Foundation provides recommendations. 9. Recognizes artifacts and limitations, such as obesity affecting accuracy. Obesity is characterized by increased adipose, fat, tissue. DEXA scans use X-ray beams to differentiate between bone and soft tissue. When there is excess fat, the X-ray beams can be scattered or absorbed differently. This altered interaction might lead to an overestimation of bone mineral density. 10. Contextual interpretation includes the overall clinical picture. 11. Treatment implications guide individualized care. 12. Nearly 50% of women and 25% of men over 50 will have an osteoporosis-related fracture. For more information, consultation with specialists and relevant clinical guidelines like those provided by the International Society for Clinical Densitometry, ISCD, and National Osteoporosis Foundation, NOF.